Welcome to our online weight loss surgery seminar. I am Dr. Ronnie Keith. We will present background information on obesity. We will discuss treatment options and their outcomes, and we will focus primarily on surgical options and compare the benefits and risks. Winter Bathay, PA, and I have worked together for over 9 years. She will be the primary presenter, and I will add additional comments on some of the more important points. The entire presentation is about 28 minutes long, and we feel critically important in preparation for having weight loss surgery. Please be attentive. Please listen carefully. We also offer in-person seminars for a more personal and involved experience.
Welcome to the Weight Loss Surgery Seminar for Dr. Ronnie Keith at Oklahoma Weight Loss Options. We will be discussing the 4 procedures we offer in our clinic today: the Roux-en-Y divided gastric bypass, vertical sleeve gastrectomy, lap band, and imbricated lap band. My name is Winter Bathay. I'm the PA that works with Dr. Ronnie Keith. I've worked in bariatrics and with Dr. Ronnie Keith since 2004, the year that I graduated. I have experience with over 2,500 weight loss procedures, meaning that I first assist in all the procedures alongside Dr. Keith. I've performed more than 10,000 band adjustments. I'm an educator for Ethicon as well as for lap band on adjustments and aftercare for other surgeons and providers. This is Dr. Ronnie Keith. He's the founder of Oklahoma Weight Loss Options and co-founder of Norman Regional Bariatric Program. He started the program on February 14th, 2002. He's performed over 4,500 weight loss surgeries and proctored over 60 other weight loss surgeons across the country. Obesity is defined as a BMI of 30 or greater. As you increase in your weight gain, you increase your obesity risk. Your disease risk is diabetes, hypertension, obstructive sleep apnea. A BMI of 40 or greater makes your disease risk extremely high. Weight gain as little as 11 pounds can increase your risk for developing type 2 diabetes. Obesity has become an epidemic. 3 in 5 Americans are either overweight or obese. It's the number 2 cause of a preventable death. Number 1 is smoking. And in the past 20 years, adult obesity has doubled and has tripled in children. Why are people overweight? The easy answer is fast food and technology. The consumption of high-calorie food, too much food, you can supersize anything nowadays. Lack of exercise, we don't go outside and play, we stay inside on iPads and computers. And then there is also considered a genetic predisposition or the fat gene. Most patients, approximately 50%, will tell me that they've been big their entire life. They were the biggest person in their class, they're the biggest person that they know. The other 50% will tell me that there was some sort of life-changing event, pregnancy, divorce, death in the family, etc. This slide shows how food portions have changed in the last 20 years. A cup of coffee 20 years ago was 6 to 8 ounces and only 45 calories. Now you go to Starbucks and get a white chocolate mocha frappuccino, which is 450 calories. Even salads have more calories than what they used to. A dressing can kill a salad. It can have 200 to 300 calories just for the dressing. The morbidity of obesity. There's different physical limitations with being a larger person. Going to a restaurant, not being able to sit in a booth because you're afraid your stomach's going to touch the table. Sitting on an airplane and having to buy 2 seats so you're not bugging the person next to you. Hygiene, cleaning yourself on a daily basis, worrying whether or not you smell or don't. These are different things that a larger person will have difficulties with and have to face in our society. There are a multitude of medical complications from obesity, including, but not limited to, the non-alcoholic fatty liver disease. What this is where fat infiltrates into the liver, causing severe inflammation. This inflammation can eventually lead to cirrhosis, the same thing that alcoholics can get. As you lose weight, you lose this fat and can reverse the fatty liver. You cannot reverse cirrhosis, but if we lose weight, we can reverse fatty liver. The other thing that I like to point out is as a patient loses weight, they can reverse their PCOS or polycystic ovarian syndrome and become pregnant. So in a woman who's having problems getting pregnant due to her obesity, hopefully with weight loss, she would be able to have children later in life. There are different weight loss options available. Medical treatment alone, diet, exercise, behavioral change is Phentermine, Slim Fast, etc. Up to 10% loss of excess body weight is considered a positive result. What that means is if you lose 10 pounds and you're 100 pounds overweight, you're considered successful. This is ineffective long term. Less than 5% of patients will sustain any significant weight loss. So 5% of the people that lost 10 pounds will keep it off. This is where we get a rebound effect of starting a weight loss program and then us taking that weight loss program away, such as Phentermine, and you gaining your weight back and then some, and then trying it again. With surgical treatment, the national average is 55% loss of excess body weight. Again, if you're 100 pounds overweight, you should lose 55 pounds. Within our practice, we are seeing this number significantly increased, 75% excess body weight loss.
Physically, we underperform when morbidly obese. It is more difficult to reach things on the floor, get out of chairs, and playing around with kids or grandkids may be almost impossible. Selective participation in activities requiring even mild to moderate exertion may seem to be severely compromised. Medically, diabetes, high blood pressure, cholesterol elevation, and obstructive sleep apnea are all too frequently associated with obesity. But with the benefits of weight loss surgery, each of those diseases have high rates of disappearance. Medical attempts to lose weight are inconsistent, and the corporate programs are frequently expensive and provide little or no sustained weight loss, only the short-term benefit. Prescription medications come with associated risk. Surgical weight loss also has risk that we will discuss in this presentation, and you must make an informed decision on benefits versus risk ratio. It is our obligation to help provide the information for you to decide. Surgical weight loss has been endorsed by diabetic associations as the first choice to control diabetes when the BMI is above 40. Surgery offers more predictable outcomes and an improvement in the medical and physical conditions that accompany obesity.
Who qualifies for weight loss surgery? Just recently, the FDA has approved the BMI of 30 or greater for the lap band. This is as little as 30 to 40 pounds of overweight. Otherwise, insurance company as well as the NIH have dictated that you have a BMI of 35 or greater with 2 comorbidities being diabetes, high blood pressure, obstructive sleep apnea, or a BMI of 40 or greater with no comorbidities. How does surgery work? There are 3 different ways surgery works. There's purely malabsorptive procedures, including the biliopancreatic diversion and the duodenal switch. We do not offer these procedures within our clinic. Dr. Keith feels that the nutritional deficiencies outweigh the benefits of the procedure. There's also restriction and malabsorption. What this means is that you will have the restriction, you eat smaller amounts, as well as some mild malabsorption. This is the Roux-en-Y divided gastric bypass. There's also the restrictive procedures, the vertical banded gastroplasty, the adjustable gastric band, and the gastric sleeve. Please take a look at our online video library for actual procedures that we perform. This is the Roux-en-Y divided gastric bypass. With this procedure, we cut the top part of the stomach off, creating a very small pouch at the end of your esophagus. It's about the size of an egg, 4 to 6 ounces is what it should hold. Then we reroute the intestine from the jejunum up to the pouch. What this does is prevent your food from being broken down at the time you take it in, and it happens later on down the road. The stomach is still there, so is the duodenum. It still produces gastric acid and those food breakdown, those enzymes that break down food. It just happens later on down the road. The advantage of the gastric bypass is that rapid initial weight loss. It also is a minimally invasive approach, which is laparoscopic surgery. We do laparoscopic surgery on all of our procedures. The comorbidity resolution, meaning that with diabetes, obstructive sleep apnea, hypertension, these things should get better, if not always get better. The disadvantages are the cutting and the stapling of the stomach, and bowel is required. This can cause a leak at any one of those staple lines that we create. There's also the dumping syndrome, which is a positive and a negative. Positive in that you do get that negative feedback for taking in fats or sugars, and negative in that you have a dumping syndrome. It's non-adjustable, meaning that I can't make your pouch smaller or bigger. This procedure is extremely difficult to reverse, however, is possible. The patients that need this procedure reversed end up staying in the hospital twofold what a primary procedure would. With the vertical sleeve gastrectomy, we start at the bottom part of the stomach and cut up along the side of the stomach, creating a small tube similar to what a garden hose looks like. We remove the excess stomach at the time of surgery. Advantages of the gastric sleeve include, again, rapid initial weight loss, however, it is less than the bypass, as well as comorbidity resolution, and it is minimally invasive approach, so again, laparoscopic surgery. The disadvantages, cutting and stapling of the stomach. You can get leaks at any part of the procedure that we cut. This is non-reversible and non-adjustable. We do see some weight regain with these patients. Because they do so well at the time of surgery within the first year, they don't make those behavior modifications that a bypass or a band would. There are possible complications of the bypass in the sleeve. Leaks, as we've discussed. The strictures are where anytime we create something, they can scar down and make things smaller. So with a bypass, the opening from the pouch to the intestine can be very small, creating a stricture. As well as with the sleeve, at any point along that staple line can scar down more than the others, causing, again, a stricture. Hernia is mostly to do with the gastric bypass because we are rerouting bowel. There can be what's called an internal hernia. Nausea and vomiting is common with all three procedures. The dumping syndrome, as we've discussed, is with the bypass. Any of the complications listed on the right can happen with any abdominal surgery. With the adjustable gastric band, we actually offer two procedures. This is the standard procedure placement of the band. The band is placed at the top of the stomach, creating, again, a small pouch above the band. We can make the band smaller or larger depending upon what you need. The adjustable gastric band with plication is the second procedure we offer with the lap band. The first 3 slides are the standard placement of the band. The next 2 slides show the imbrication or plication of the stomach below the band. What this is us folding the stomach in on itself and creating a tube or sleeve below the band. What we've seen with this is an early increase in weight loss as well as fewer possible prolapses. Prolapses are herniation of the stomach from below the band above the band. When we are tying the stomach down below the band, we are not seeing any prolapses. Possible gastric banding complications include port or tubing issues. This is a foreign body, so you can get issues with foreign bodies. Band slippage or prolapse, which as we have discussed. Erosion can happen. It's less than 1% of the time, but where this band goes through the stomach lining and ends up inside of the stomach. You can also get upper stomach pouch dilation as well as esophageal dilation. Usually this is from overeating and not measuring your food. You can also get nausea, vomiting, cardiac, and blood clots with any of the procedures and any abdominal surgery. Steps to surgery. Attending a seminar, which could be online or in person. Completing your seminar paperwork. Then we will schedule you for an appointment to meet with our surgeon, Dr. Ronnie Keith, and discuss the procedure that you've chosen and a plan for your procedure. We do the Big 4 consults within our office. That's dietary consultations, mental health evaluation, physical therapy, and support groups. Any additional tests or consults need to be done prior to surgery, and this should have been discussed when you met your surgeon. Pre-op diet class and orientation is done within our office. This is where you will meet our bariatric coordinator, who will discuss how to go through the hospital stay. Finalizing surgery plan is at your pre-op discussion. We will sign consent forms and go over any last-minute details. And then you go to surgery. Dietary counseling is within our office. Our dietitians will follow you through your preoperative phase, and we have integrated them into the postoperative care of our patients. They are also available at group sessions, including support groups, and they are available anytime after surgery that they are needed through email, phone calls, or to just come in. Why exercise? Everyone knows why you should exercise. This is how you lose weight and excess energy out, decreased energy in, you will lose weight. You will also gain muscle mass, which is very important for after surgery as well. Surgery helps make it possible to control your calorie intake and thereby controlling your weight. Behavioral change and support is very important for you to maintain your weight loss in the long run. Everyone's worried at this point about losing weight, and our job within our clinic is for you to maintain the weight that you do lose. You will lose weight. I want you to maintain it, and that's where behavior modification comes in. We have licensed mental health providers within our office to help you at any point post-operatively. Preparing for surgery. You should be up to date on all your screening tests, including colonoscopy for everyone who's over the age of 50 and a mammogram for women over the age of 40. This should be done through your primary care provider. Please bring these tests with you to your appointment with Dr. Keith. If you are a smoker or chew tobacco, you need to stop. Attending an Oklahoma Weight Loss Options support group. There are lists of dates and times of the support groups on our website. Get moving. Increased activity actually decreases your risk for lung and pneumonia complications after surgery. The cost of surgery. For insurance patients, our nurses will call your insurance company and find out if you have benefits for surgery after this seminar. For our self-pay patients, we have the best self-pay prices in the region. We have no disclaimer that will add additional costs to your surgery. Outpatient surgery is the lap band or imbricated lap band. Our inpatient surgeries are the sleeve as well as the bypass. If a patient has surgery on Monday, they should go home on Wednesday with a sleeve or a bypass. Returning to work depends upon your job. With a band, most patients should go back to work within a week. With a bypass or a sleeve, it's 2 to 4 weeks. We limit the activities to walking within the first 6 weeks. This is to prevent ports from flipping within a band procedure and to prevent hernias with a bypass or a sleeve. How is greater weight loss achieved? With regular follow-up appointments. We didn't come up with this all on our own. This is something that Dr. Keith has done for a very long time and has come up with this formula for the best weight loss to be achieved. Proper nutrition through our dietary education, regular exercise, increase your leisure time activities, mow the lawn, do some gardening, go out for a walk with your significant other. Honest communication. Come into our office and tell us the truth. If you come in and you lie to me, you're just lying to yourself. We're here to help you and guide you through the process. Appropriate adjustment of your gastric band. This is where I come in, and I'm the best at it. If you listen to me, you will lose your weight with your gastric band. Support within our office, as well as support at home and friends and family. If you don't have the friend and family support, go to the Oklahoma Weight Loss Options support groups. Follow-up appointments happen at 1 week with Dr. Keith to check incisions and make sure you're doing okay. And then with the rest of our procedures, it's approximately 4 to 8 week cycles in the first year. After the first year, we will see you annually. Just some final thoughts for you. Surgery is the most effective treatment for morbid obesity. It requires change to be successful. It's not for everyone. It's not a quick fix, and it's definitely not without risk.
Procedure. Bear with me, this is about 4 minutes long, but I think important in helping to select a procedure if you have not already done so. Many, and probably more accurately, most persons wanting weight loss surgery have already decided on a primary procedure. The options include gastric bypass, lap band, or sleeve. Influences from family, friends, and sometimes doctors will move the patient to their choice of surgical procedure. However, about 30% of patients studying their options will have some difficulty in deciding what is best for them. They may have heard a coworker who has a cousin somewhere that worked with this guy whose aunt had surgery and gained all of her weight back, so they're not interested in that procedure. Or a patient may have just looked sick all the time, or this or that. The truth is there are complications with any surgery, not just weight loss surgery, and failures do occur with weight loss surgery. So let us look at this a bit differently. There are 3 common weight loss surgical procedures: bypass, lap band, and sleeve. A 4th, the duodenal switch, has such potential for nutritional problems that we do not recommend it? Which procedure do you not want? The bypass requires rearranging intestine, dividing and hooking things up. Generally, weight loss is predictable, but some folks do not like all of the rerouting of the intestines inside their body. Do you object to this? The band requires placing an implant, medical-grade silicone, inside the abdominal cavity, around the upper portion of the stomach, and then another implant, the port, is placed under the skin. Some people just do not favor having things inside their body. Do you? The sleeve requires removal of 70 to 80% of the stomach and discarding it. This is truly the only non-reversible option of the three, and throwing away most of a good stomach and inability to reverse just turns some people off. What about you? Actually, any of the three procedures will help a motivated and disciplined patient succeed with their goal of weight loss, just as a non-motivated, non-compliant patient will regain their weight with any of the three procedures. In our practice, having performed almost 5,000 procedures and seeing hundreds more patients that have come to us for either revision, reversal, or conversion of previous surgery, because of complications or failure to maintain weight loss, we have made some conclusions. The gastric bypass is by far has the highest rate of complications that require additional surgery and the highest degree of nutritional deficiencies. Until the past few years, it was our most commonly performed procedure, but now it's less than 10%. Will you lose weight with the bypass? Yes. Can you regain that weight? Yes. Does it have the highest rate of complications? Absolutely. The lap band has the fewest complications that require additional surgery and almost no nutritional deficiencies. Can you lose weight with this procedure? Yes. And can you regain that weight back? Certainly, if you are non-compliant. The sleeve has a low to moderate risk for nutritional complications, but if a leak occurs, it may take months to heal. Leaks are rare, but they do and they will occur, and hospitalization can be weeks to months. Sleeve patients will lose weight. Sleeve patients, just like the other patients, if not compliant, can regain weight. Our practice outcomes, not from some university back east, actually show very little difference between procedures in our practice. An example, if all patients are 100 pounds overweight, our patients at 2 years will average having lost and kept off 70 plus pounds of that 100 pounds, so they lose approximately 70% of excess weight. Surprising to some, our lap band patients' weight loss exceed the sleeve and are just a few pounds behind the bypass and have far less complications requiring additional surgery and almost non-existent nutritional deficiencies. Why do our lap band patients do so well with the general thought of many patients and even doctors that lap band patients do not lose weight as well? It is our educational program. It's the post-operative care or aftercare that we provide. Please review the video on lap band adjustments for additional information on this. We are the busiest weight loss surgical practice in Oklahoma and will continue to offer all three procedures. Plus, we will accept patients on a one-by-one basis from other practices that may have complications. We want you to be the final decision maker on which procedure you have after being fully informed. So spend some time, self-study, and read the pluses and minuses of the procedures. View the video section of this website to obtain additional information. Check out the anatomy and the anatomical changes, and then view a condensed video of the procedure. Yes, ask your spouse, other trusted family member, and your doctor what their opinion is.
Thank you for attending our online weight loss seminar. Hope to see you soon.